It gives me immense pleasure to welcome you all for this momentous occasion on behalf of Apollo Proton Cancer Center. Today, we are gathered here not only to celebrate a milestone in breast cancer care, but also to reaffirm our commitment to advancing healthcare in India and beyond. Breast cancer is a persistent health challenge in India, where 1 out of every 4 women is diagnosed with breast cancer. Tragically, more than 50% of these cases are diagnosed at an advanced stages, making survival more difficult. While survival rates in India stand at 60% compared to 80% in the United States, these statistics remind us that early detection and innovative treatment options are critical in improving outcomes. At Apollo Proton Cancer Center, we are proud to announce India's first successful endoscopic mastectomy with reconstruction, a novel procedure that combines minimal invasive techniques with state of the art technology. This innovation allows us to treat breast cancer while preserving the patient's physical appearance and minimizing recovery time, and addressing the emotional and psychological needs of the patient. Our dedicated team of experts, led by Dr. Manjula Rao, has defined has, re, has redefined what is possible in cancer care by combining technology, expertise, and a compassionate patient-centric approach. With every step, we strive to set new benchmarks and pave way for future advancement in oncology. Thank you for being here today and for supporting our mission to transform cancer care. Together, we can inspire hope and make a meaningful difference in the lives of countless individuals. Thank you.
It gives me great pride here today to stand in front of all of you and talk about the first endoscopic mastectomy that's been done in the country. And it's fantastic, and we feel really happy that we're able to bring in this innovative technique which is centered on a patient-centric approach to all of you. And this is not just a personal achievement. This is an achievement for the organization, Apollo, and also an achievement for the country, where we believe in making everything available for our citizen in the country itself, and to close the care gap and ensure that everyone gets equitable treatment. So as we all know, breast cancer is the commonest cancer in the world as well as in India. Dr. Praveen has already highlighted that. And it is alarming to know that the rates of breast cancer is increasing at 0.5% every year. But there has been tremendous improvement and advances in the diagnosis and management of breast cancer over the last 3 to 4 decades, and it continues as I speak. Every day there's a new guideline, and every day there is a new advancement that comes, which we ensure that we make available to the patients we treat. So gone are the days when we use such grotesque methods of chopping off the breast or burning the breast for somebody who's been affected with cancer. Today, the highlight is on conservation of the breast. It is on conservation. It is on saving the organ rather than removing it. But in breast cancer care, we have gone a step forward. We believe in not just saving the organ, but ensuring that it looks exactly the way it was before we had operated. And that is made evident by the pre and post-op pictures in this patient, who's another patient, not the patient we're discussing today, where you can see that pre and post-operatively it looks the same. So breast conservation, as we know, it helps to improve the body image of a woman, helps instill confidence and improve psychosocial outcomes. The emphasis today is beyond just cancer cure, and we're moving towards improving the patient's quality of life. However, there are certain patients, we know Dr. Praveen has also mentioned to you that 50% of the patients who present to us today present in advanced or locally advanced stages. So there are those women who still require removal of the breast. Now, what do we do for such women where we cannot conserve? So in this case, we try to reconstruct the breast, or we do what is called conservative mastectomy. So conservative mastectomy is where we conserve the skin and the nipple of the breast. So it's either a skin sparing mastectomy or a nipple sparing mastectomy, and then we reconstruct it using implants or the patient's own body tissues. So this is the picture of a breast, and when I talk about a conservative mastectomy, what we have done today for our patient using the innovative and the novel endoscopic approach is where we retain the skin of the breast and we remove the glandular tissue, including the tumor. We try to save the skin and the nipple areolar complex. For patients where the nipple shows evidence of tumor, we have to excise the nipple as well. If the skin is involved, we remove the skin as well. But traditional minimal access breast surgery, nipple sparing mastectomy, if you see, you use incisions like this over the breast, right? So once it heals leaving behind a scar. And that is what we're trying to avoid. A breast is a very important organ for a woman, contributes to her confidence, her psychosocial scores as well. And that is where minimal access breast surgery comes into the picture. So this has developed over the last 2 decades, and we use methods to achieve the same oncological safe surgical margins as in conventional cancer surgery, but with smaller incisions, fewer incisions. And we use specialized surgical instruments to give better visualization of the operative field while keeping the incision very small and hidden in inconspicuous areas. So if you see from the previous slide, these are the kind of incisions that are put on the breast. But if you can see in this picture, the incision is taken in the lateral mammary crease, which remains well hidden. And when we talk about minimal access breast surgery, it is any approach or any instrument, any technology that helps you achieve this. It can be robotic, but in this case, we have introduced a very novel technique called the endoscopic approach. And why is it special? We will come to that in a minute. The advantages of endoscopic breast surgery is that the incisions are small, they're very well hidden. It has shorter post-operative recovery, offers excellent cosmesis, and preserves the body image of the patient. In patients with cancer, it helps us remove the cancer as well, and there's improved patient as well as surgeon satisfaction. The indications for endoscopic nipple sparing mastectomy are 2. Either in patients without a cancer, right? But those who are at high risk for developing the cancer, be it because of genetic mutations or a very strong family history, they have to undergo what we call a prophylactic mastectomy. So in such women, we can utilize this technique. In patients with cancer, we can consider it in those with very early breast cancer, smaller tumors, and hopefully without skin involvement. But you must remember that the selection criteria for any surgery with regard to breast cancer, be it conservation or be it minimal access breast surgery, the selection criteria is very stringent, and this decision has to be taken after a close discussion with the cancer surgeon. So coming to our patient who underwent this technique, she's a 46-year-old lady diagnosed with an early breast cancer. The nipple did not seem to be involved on the mammogram and MRI extensive breast imaging. However, she was not suitable for a breast conservation, which is why we had planned her for removal of the breast, or what we scientifically call modified radical mastectomy. And I'm so happy here to say that this lady, who is a homemaker, was very, very keen on reconstruction, and she demanded it, in fact, and said, you know, I care about my body image. So we decided to go ahead with an endoscopic nipple sparing mastectomy for her, and we have already seen the advantages. I've discussed it in the previous slide. Now, why did I choose the endoscopic technique? One, because I can perform this procedure without using special or expensive equipment. The instrumentation is already available in the operation theatre, and by this I mean not just our operation theatre in Apollo where we have everything available to us, but any hospital in the country with the basic instruments, they can go ahead with this technique. It has very good applicability and reproducibility in all hospitals in India without requiring large investments, and it assures the best and the latest advanced treatment for all our citizens. They don't really have to leave the country, go elsewhere to get the latest technology or the latest treatment now, and I think that is what makes it special. Moreover, I think, again, like I said, it's a matter of pride for us that we were able to bring this technique into the country, and this is the first time an endoscopic mastectomy has been performed in India. It has not been performed prior to this. The endoscopic, and I say endoscopic mastectomy here because that is what we have done for this patient, but by this means you can also do a breast conservation, you can address the axilla, etc. So I'm going to go into this description of the surgery. There are some images here. I'm just giving you all fair warning in case anyone's maybe disturbed by blood or vivid imagery. So this is where I've put this video up to show you the incision that we take. So a traditional nipple sparing mastectomy would mean I would take an incision around the entire lateral aspect. But if you can see, I have just marked a 3.5 to 4 centimeter in the lateral mammary crease. And then we create a pocket. We open up the incision, we create a pocket, and we place a polythene bag, which is, it's not your regular polythene bag. It's a specialized one made for medical use and which is used to attach to the port. It helps create the tunnel for us to put our instruments inside to go ahead with this procedure. And this is a gel port that we have used in order to enable this. And this is how we're doing the procedure. So, in traditional nipple sparing mastectomy, I would be standing. We would have taken a very, very long incision. There would be, retractors put inside the breast, stretching the skin very uncomfortably and hampering the blood supply. But in this, if you see very comfortably, we're sitting and we have the instruments and we're watching the dissection. We're watching the television and performing the dissection. So, again, another speciality of this technique is usually endoscopy or laparoscopy is something that is done for abdominal surgery, where the abdominal cavity is very big and you have a lot of space to put in the instruments. But the breast, if you see, is a very contained organ and we have very limited space, and that too we go in only through a 3.5 or 4 centimeter incision. But this is how putting in these instruments, going inside, we get adequate visualization to go in and do this surgery. And this is the final specimen which we have removed the entire breast through that 3.5-4 centimeter incision. And as with any nipple sparing or skin sparing mastectomy, once the breast gland is removed, we must reconstruct it using either silicone implants or the patient's own body tissues. So in this case, we did an autologous whole breast reconstruction using the tissue from the patient's abdomen. So the patient was very, very happy, and it's a brilliant feeling after major surgery. You walk into the recovery and she's smiling at you and she says thank you. So this was gratifying not just for our patient but for us, for me and my team as well. Volume. So we just have a small audio bite from the patient. She's sent us, she was kind enough to give us her views.
மார்பகத்துல கட்டி இருந்தது. அது சாதாரண கட்டி நினைச்சது, கேர்லெஸ்ஸா இருந்துட்டேன். நமக்கு ஏன் இந்த நோய் வரப்போகுது அப்படின்னு சொல்லிட்டு கேர்லெஸ்ஸா இருந்துட்டேன். அதுக்கப்புறம் கட்டி கொஞ்சம் பெருசான மாதிரி தெரிஞ்சது எனக்கு. நான் செங்கல்பட்டுல ஜிஎஸ்டிக்கு போய் பார்த்ததுல அவங்க கொஞ்சம் டவுட்டா இருக்கு அப்படின்னு சொல்லிட்டு ஒரு சில டெஸ்ட்டுகள்லாம் எழுதி கொடுத்தாங்க. டெஸ்டெல்லாம் எழுதி கொடுத்து மேமோகிராம் எடுத்தாங்க. மேமோகிராம் எடுத்துட்டு அடுத்த நாள் இன்னொரு டெஸ்ட்டுக்கு வர சொன்னாங்க. அப்ப அதுக்கு நான் அங்க போகல. மறுநாள் என் தம்பி கிட்ட டிஸ்கஸ் பண்ணேன். அவன் புரோட்டான் ஹாஸ்பிட்டல் அப்போலோ புரோட்டான் இருக்கு அங்க வான்னு சொன்னாங்க. அங்க போனேன். அங்க டாக்டர் மஞ்சுளா மேமும் பார்த்தேன். அவங்க என்ன நான் ஏற்கனவே டிவில பார்த்துருக்கேன். அவங்க நான் நியூஸ்லாம் நிறைய பார்ப்பேன். அதுல அவங்க கொஞ்சம் பார்த்துருக்கேன். அவங்க அப்ப எனக்கு ஞாபகம் வந்தது. அப்புறம் அவங்க கிட்ட என்னோட ப்ராப்ளத்தை என்னோட கஷ்டத்தை எல்லாமே சொல்லிட்டேன். நான் கொஞ்சம் என் வீட்டுக்கார உடம்பு சரியில்லை, அவருக்கு நிறைய ஸ்பெண்ட் பண்ணியிருக்கு, நிறைய செலவு பண்ணியிருக்கு. அதனால என்னோட ப்ராப்ளத்தை எல்லாம் சொன்னேன். எனக்கு 2 குழந்தைங்க இருக்காங்க, அவங்கள பார்த்துக்க ஆள் இல்லை. அதனால நான் அப்போல போயிருந்தேன். அங்க வந்து மேம் பார்த்தேன். மேம் எனக்கு ஹெல்ப் பண்ணாங்க. சர்ஜரி பண்ணி எனக்கு கியூர் பண்ணி நல்லபடியா செங்கல்பட்டுக்கு ஆரம்பிச்சாங்க. அதுக்கான செலவும் எனக்கு கம்மி பண்ணி எனக்கு முழு ஒத்துழைப்பு டெஸ்ட்டுக்கு கூட எனக்கு 30% கம்மி பண்ணி சொல்லி அங்க மேனேஜ்மெண்ட்டை பேசினாங்க. அம்மா எதற்கே சொன்னாங்க. இதுக்கான முழு நன்றியும் மஞ்சுளா அம்மாக்காக நான் தெரிவிச்சுக்கிறேன். அவங்க எனக்கு சர்ஜரி இத பத்தி எனக்கு சொன்னாங்க. ஒரு சில டெஸ்ட் எல்லாம் எழுதி கொடுத்தாங்க. அதெல்லாம் எடுத்துட்டு அப்போ டாக்டர் எனக்கு வெங்கடாமன் டாக்டர் பார்த்தாரு. அவரும் எனக்கு ஹெல்ப் பண்ணாரு. அவரும் எனக்கு சர்ஜரிக்கு எல்லாம் ஹெல்ப்பும் பண்ணாரு. 2 பேரும் டிஸ்கஸ் பண்ணி எனக்கு சர்ஜரி பண்றதுக்கு முடிவு பண்ணாங்க. சர்ஜரி பண்ணி இப்ப நான் நல்லா இருக்கேன் சார். எனக்கு டாக்டர் அப்போலோ வந்ததுல டாக்டர் அம்மா எனக்கு ரொம்ப மார்பத்தை காப்பாற்றி எனக்கு ஆபரேஷன் பண்ணி கொடுத்துருக்காங்க. ரொம்ப டாக்டர் அம்மாக்கும் மஞ்சுளா அம்மாக்கும் ரங்கராமையாக்கும் ரொம்ப நன்றி சொல்லுங்க சார்.
Thank you very much. This was me. This is me and my team. 1 or 2 members are actually missing from this picture, but this was the team. We were at the forefront. However, the contributions of those at the back end has been much more valuable, and I would like to highlight that. Be it the OT staff, the OT supervisor, our nursing supervisor, Ms. Susan, our medical superintendent, Dr. Praveen, our CEO, Mr. Karan Puri. I think we must thank them as well, because to be honest, to start something new, to introduce something new to the country is not possible without the wholesome support of the entire team. Surgical as well as the admin and the management. I would also like to express my gratitude for the constant encouragement and support of our central team as well. We have our president, Mr. Dinesh Madhavan here, who continues to push us to excel in everything that we do. Always my heartfelt gratitude to our director, Mr. Harshad Reddy, and our executive vice chairperson, the gracious Ms. Preeta Reddy. They're always a phone call away and very, very supportive of everything that we do. And this whole talk and everything would be incomplete without me taking our respected chairman's name, Mr. Pratap Reddy, who has been a constant driving force for us to keep introducing new technology, because it is his vision and his ethos that is filtered down to all of us and which keeps propelling us to provide, not just introduce the best technology to the citizens of our country, but to ensure that it reaches the common man. So thank you very much. Thank you.
நீங்கள் என்ன ரீகன்ஸ்ட்ரக்ஷன் பண்ண போகிறீங்க? ஏன்னா இம்ப்ளான்ட்னா அது அரை மணி நேரம் வேலை. ஆனால் நீங்கள் ஆட்டோலோகஸ் பண்ண போகிறீங்கன்னா இட் வில் டேக் 5 to 6 hours. ஸோ தேட் மேக்ஸ் அ பிக் டிஃப்ரென்ஸ். ப்ளஸ் பேஷண்ட்டோட கண்டிஷன் எப்படி, டயபெட்டிஸ், பிளட் ப்ரெஷர், ஹார்ட் கண்டிஷன்ஸ், ஏன்னா அதுக்கு மேலே வி ஹவ் டு டிசைட் அவங்க வந்துட்டு ஐசியூவில் வைக்க போகிறோமா, ஐசியூ கேர் வேணுமா, இல்லைன்னா வார்டுக்கு அவங்க போகலாமா. So these are the various factors which depends. ஒரு ரேஞ்ச் இருக்கும். பட் நீங்கள் ஜென்ரலாக பார்த்தீங்கன்னா ஒரு 5 to 7 lakhsக்குள்ளே இந்த ப்ரொசீஜர் நாங்கள் பண்ணலாம்.
After that, is there any requirement for chemotherapy or radiation?
100%. What we are highlighting today is a new surgical technique, but cancer care remains the same. Cancer care is multidisciplinary. உங்களுக்கு சர்ஜரியும் பண்ணணும், chemotherapy plus or minus, radiation plus or minus. அது நாங்கள் எப்படி டிசைட் பண்ணுவோன்னா இந்த பேஷண்ட்டோட நோய் அதோட என்ன பயாலஜி என்ன கேரக்டரிஸ்டிக்ஸ் பயோப்சி ரிசல்ட் என்ன based on that we decide.
Please. Thank you.
Doctor, can you expand a bit about the selection criteria? Can you expand a bit about the selection criteria? You mentioned that it's very stringent.
Yes, thank you for that question. I think that's brilliant. So let me tell you that minimal access breast surgery is, it has been accepted and it's been put into the guidelines for prophylactic nipple sparing mastectomy, right? When a patient does not have a cancer. There are multiple centers around the world, the few centers that I mentioned, where it is being done for early breast cancers as well, right? And in those, when we're doing it for a patient with cancer, we try to do it under trial setting. And also, few things that we need to keep in mind: the size of the tumor with regard to the breast, skin involvement, nipple involvement. So what we always plan for is a nipple sparing mastectomy. But on table, no matter how small the tumor is, no matter how far away, we always take the nipple under tissue and we send it for frozen section like in this case. We check whether it has cancer. If it has cancer, the nipple is excised. So cancer control is number one. And then comes cosmesis and the rest. You can keep improving the cosmesis, but we get a chance to cure the cancer just once.
And the tumor size for this patient was relatively small.
Yes, it was 2.5 centimeters.
How to reconstruct the tissues in our body after surgery?
Okay, so whole breast reconstruction, can I do this in English or Tamil? Okay. So basically ரெண்டு ஆப்ஷன் இருக்கு. Either நாங்கள் வந்துட்டு ஆர்டிஃபிஷியல் இம்ப்ளான்ட் சிலிகான் பிரெஸ்ட் இம்ப்ளான்ட் நாங்கள் வச்சுட்டு நாங்கள் இது பண்ணலாம். ஸோ அந்த ஓப்பனிங் பார்த்தீங்க இல்லையா, அதுக்குள்ளே நாங்கள் அந்த இம்ப்ளான்ட் நாங்கள் அப்படியே இன்ட்ரடியூஸ் பண்ணிடுவோம். ரெண்டாவது வந்துட்டு யூஸிங் அந்த பேஷண்ட்டோட உடம்புல எந்த டிஷ்யூஸ் எங்கே ஃபேட் இருக்குது நாங்கள் பார்ப்போம். ஸோ வயிற்றில் இருக்கா, தைஸில் இருக்கா, பட்டக்ஸில் இருக்கா. Based on that we decide, and it depends, you know, like for example இந்த பேஷண்ட்டுக்கு கொஞ்சம் யங் ஏஜாக இருந்தாங்கன்னா breast வந்துட்டு கொஞ்சம் what do I say ரொம்ப அந்த ஸ்கின் வந்துட்டு ரொம்ப சாகியாக இல்லைன்னா நாங்கள் இம்ப்ளான்ட்டும் போட்டிருக்கலாம். But because of the patient's age and அவங்களோட body characteristics, we decided to use அவங்களோட body tissues வச்சுட்டு autologous whole breast reconstruction பண்ணோம்.
கல்ச்சுரல்ஸாக என்னென்ன மெத்தடில் பண்ணுவாங்க, இதுலேருந்து என்ன டிஃபர் ஆகுது இந்த எண்டோஸ்கோபி?
என்ன கல்ச்சுரல்?
பொதுவாக பிரெஸ்ட் கேன்சர் வந்தவங்களுக்கு யூஸ்வலாக என்ன மாதிரி சர்ஜரி பண்ணுவாங்க, அதுலேருந்து இந்த எண்டோஸ்கோபி மாஸ்டர்டோமி எந்த அளவுக்கு வேரி ஆகுது? இந்தியாஸ் ஃபர்ஸ்ட்னு சொல்லியிருக்கீங்க.
ஆமாம், வேரி ஆகுதுன்னா because this is the first time it is being done using endoscopic method in the country. இல்லைன்னா what I do routinely, like I don't know if you heard initially, I've told you, and the incision வந்துட்டு ரொம்ப நீளமாக இருக்கும். It will be in the entire side of the breast. You'll have to lift the entire breast tissue, use retractors, அந்த ஸ்கின்னை ரொம்ப ரிட்ராக்ட் பண்ணி புல் பண்ணி நாங்கள் பண்ணணும். இல்லைன்னா அதை அவாய்ட் பண்ணணும்னா பிரெஸ்ட்டுக்கு மேலே ஒரு நீளமாக கீட் போடணும். ஸோ அது காஞ்சப்புறம் there'll be a huge scar on the breast. So we are aiming for cosmesis, we are aiming for quicker recovery. So இது நீங்கள் பார்த்தீங்கன்னா incision வந்துட்டு 3.5 centimeters அவ்வளோதான். And that is one small band-aid after such a long procedure. The 3-4 hours after surgery நான் வார்டுக்கு போயிட்டு பார்க்கும்போது she's smiling, she said thank you, and I think that is the biggest reward doctor can get. So again, to answer your question, this is the first time this technique is being done in India.